Today I'm going to talk about next generation biomaterials for dental pulp tissue immunomodulation. So we know dental pulp is the organ which is inside the root canal, and dental caries or trauma leads to inflammation, irreversible damage to the dental pulp tissues, and consequently the pulp tissue necrosis, resulting in loss of tooth vitality and eventually into the apical periodontitis, so which might end up in extraction or endodontic treatment. So traditional root canal treatment is removing the necrotic tissues, debriding the canals, drying the canals, and then filling with inert material using a sealer cement. So that is the traditional way of doing saving a tooth after the necrosis. Post-treatment, there is apical periodontitis happening in 5 to 15% cases even after following standard protocols. So how to avoid that? We should plan some regenerative therapies like a biological procedure designed to develop, regenerate damaged or diseased dental pulp. So this comes under tissue engineering. So in tissue engineering, there are 3 important factors which has to be considered. One is the stem cells. So they synthesize the new tissue matrix. And the bioactive growth factors which promote and facilitate the functionalities. And the third is the biomaterials such as scaffolds, and they act like the extracellular matrix which promote differentiation, multiplication, and biosynthesis. So these are the 3 elements which are important in any kind of tissue engineering. And what are the novel treatments for infection-induced pulpal inflammation? So what can we do instead of a root canal treatment? What can we do to save a tooth? So the critical therapeutic properties of an ideal biomaterial should be antimicrobial, and it should immunomodulate. Immunomodulate in the sense it should reduce the inflammatory cytokines and produce anti-inflammatory mediators to stimulate repair. So there are 2 regenerative therapeutic approaches for treating pulpal inflammation. One is a cell transplantation, the other is a cell-free therapy. So cell transplantation is nothing but we are taking the dental pulpal stem cells and then placing inside the compartment where we need the organ or tissue to grow and allow them to grow. So before doing that, we need to isolate the dental pulpal stem cells either from the same patient or as autogenic or from a different person as allogenic. We have to multiply them, expand them in the in vitro condition, and then again place them back inside the compartment where it has to grow. It is actually a little technique sensitive, and it is far from conventional endodontic root, replacing a conventional endodontic root canal therapy. The other is a cell homing. Cell homing is nothing but an effective recruitment of the stem cells or their progenitors to the compartment through chemotaxis and avoiding the challenges associated with the cell transplantation like the in vitro expansion of the cells and immunotoxicity if it is transplanted from some other person. So it is a safer, more cost-effective and clinically translatable therapeutic option. So how they do, they just evoke bleeding beyond the apex, allow the periapical or the periodontal blood vessels to cool inside the root canal, and develop pulp-like tissue. We do not develop pulp, but they develop a pulp-like tissue, and these are some animal experiments which have already been done. But what happens when the formed dental pulp tissue mostly resemble the periodontium or the bone, since it is coming from the periapical or the periodontal region, and we see the bone tissue or a cellular cementum in the dentinal wall. So this is what happens in cell homing technique. So these are the novel treatments which are applied for dental pulpal replacement. And what happens when a biomaterial is placed inside a human body? It immediately has some immune response. So how is the biomaterial immune system interaction? One is, first, when we place a biomaterial, there is a tissue injury which induces inflammation, and eventually the inflammation reduces, which causes the wound healing property. So it is an essential factor in determining the biocompatibility and immunomodulatory properties of the material which we are using for regeneration. So undesired immune response can reduce the device functionality, effectiveness and durability due to hindrances in the interaction between the biomaterial and surrounding tissue. So the material itself should not be immunogenic to that particular environment. So after a biomaterial implantation, the fibrinogen and the other proteins from the blood and the interstitial fluid, they come and attach on the surface of the biomaterial, and that process is known as biofouling. And the receptors of these proteins function as adhesion substrates whereby they attract the platelets and macrophages which get activated, and they change the pro-inflammatory environment into an anti-inflammatory environment by secreting the cytokines. So fibrin-rich clots are formed and deposit cytokines and growth factors, which serve as the provisional matrix for cell adhesion, migration, as well as providing signals to initiate inflammatory and wounding, anti-inflammatory and wound healing process. So with advances in tissue engineering and regenerative medicine, along with greater understanding of the pathophysiology of the immune system, the biomaterial design or architecture requiring innovative manufacturing strategies are fundamental to conferring good biological compatibility. So we need the biomaterial to get to be non-immunogenic to that host, and we need the biomaterial to integrate with the extracellular environment of that particular tissue, and then provide the desired effect, as that is regeneration in this instance. So what are the recent advances in immunomodulatory biomaterials? So we are seeing the immunomodulatory biomaterials. So the change from M1 to M2 phenotype. M1 means macrophage. Macrophage 1 and macrophage 2. Macrophage 1 is the pro-inflammatory kind and macrophage 2 is the anti-inflammatory kind. So the change from M1 to M2 macrophage is at the appropriate phase of an inflammatory response is critical, not only to prevent the infection and removing necrotic tissues, but also to promote healing. So that particular time it has to change from M1 to M2. If M1 prolongs, there is more inflammation. If M2 cannot happen earlier because inflammatory reaction only supplies the macrophages to that area. So what are the three recent advances in biomaterials? We have nanoparticles. What are nanoparticles? Particles are which are in the nanometer size. Studies show that the dose, size, route of administration, composition and surface properties of a nanoparticle decides the fate of the macrophage. So that these factors decide the fate of the macrophage, whether it should be M1 or M2. So study had developed an antibiotic medication using chitosan-based nanoparticles, which were co-cultured with the periodontal ligament fibroblast with macrophages, and they found out that it transferred the M1 phenotype to M2 phenotype by studying the cytokines which are released during the co-culture. And one disadvantage of nanoparticles is it can, depending upon the size and the composition, the charge of the particles, it can cause immunotoxicity in the local area or in systemic tissues. So this is the one disadvantage of using a nanoparticle. The other one is a hydrogel. So an injectable, the study showed an injectable hydrogel containing quercetin and bioactive glass, which was used to regenerate articular cartilage. So quercetin is a flavonol which is found naturally in vegetables and fruits. They have a potent antioxidant and anti-inflammatory property, which was studied by studying the mediators produced. So they had changed from the pro-inflammatory cytokines like IL-1 beta, IL-6 and TNF-alpha. These are the pro-inflammatory cytokines, and they activated the anti-inflammatory cytokines, which is mainly the IL-10 and tumor necrosis factor, not tumor necrosis. So why they studied the articular cartilage regeneration in a pulp regeneration? Because articular cartilage lacks blood vessels, lymphatic cells and nerve cells, which is similar to the characteristics observed in a necrotic pulp tissue. So we can translate this for a pulp tissue regeneration as well. So we compared the study for articular regeneration, articular cartilage regeneration. And since it is a hydrogel, it can be in an injectable form, which can go into complex anatomies like in case a root canal system. And this composite hydrogel led to macrophage polarization, M2 polarization, which reduced inflammation and inhibit the extracellular matrix degradation by down-regulating the expression of inducible nitrous oxide synthase. So this inducible nitrous oxide synthase causes extracellular matrix degradation, which is the base for any regeneration to happen. If that is degraded, then the regeneration will not happen. So this composite hydrogel had M2 macrophage affinity, so this prevented this extracellular matrix degeneration. And injectable study, another study used an injectable microsphere which had this heparin modified genital nanofibers. So nanofibers are also a kind of regenerative scaffold which can, material which can be used for regeneration, which polarizes the M1 macrophage to the M2 phenotype. And this injectable microspheres has benefits being administered minimally invasively and quickly adapting to complex defects such as inside the root canal system or periodontal defects. So these are the hydrogels which are used for immunomodulation. And the last one is the scaffolds. So the scaffolds are constructed using, there are different kinds of scaffolds used. There are polylactide, poly-N-lactic acid, polyglycolide, lactic acid, propoglycolide. So these materials can be used to prepare scaffold, where one material which is very hard to dissolve, that can be formed as a outer covering, and a core material which is easily degradable can be placed inside, so that goes into the particular area and sits there for some time for the regeneration to happen. So there are studies which shows scaffolds which has osteogenic differentiation capabilities, and this is called as in situ tissue engineering scaffold, ITE scaffold, which releases the basic fibroblast growth factors and bone morphogenic proteins. Basic fibroblast growth factor is the first growth factor which was isolated from this family, which is essential for wound healing due to its benefits as a potent inducer of vascularization, proliferation and migration. So for any regeneration to happen, we need blood vessels, nerves and the extracellular matrix for the tissue growth. So this fibroblast growth factor, they reduce the pro-inflammatory factors and polarizes the LPS stimulated macrophages. LPS is the inflammatory secretion from any bacteria that stimulates the macrophages towards anti-inflammatory M2 phenotype through AKT, P38, NFK beta signaling pathways, and this is the signaling pathways which is necessary for the shift of M1 to M2 macrophage. Nuclear factor kappa beta is the important signaling pathway which causes this macrophage switch. And there are many studies which shows many kinds of scaffolds which are towards the macrophage 2 polarization. That means they can cause immunomodulation in that particular area. And what are the desirable biomaterial scaffold properties to induce immunomodulation? So we are going to study about the scaffolds. We saw nanoparticles, hydrogels as scaffolds. In that, the immunomodulatory capacity of these scaffolds. So what we need is, porosity. Porosity is the holes which we need in the scaffolds. If the pore size is very small, the cells will not be able to migrate inside and develop. If the pores are very large, then the scaffold material will not be strong enough. So that has to be kept in control, the pore size. So we need to know the porosity. And the surface wettability and chemical properties. Surface wettability, whether it's hydrophilic or hydrophobic. In a hydrophobic biomaterial, the proteins might open up and the fold is not formed properly and the proteins cannot adhere to the biomaterial. So we have to develop a hydrophilic scaffold, and the surface charge also plays an important role. Negatively charged biomaterial is more regenerative in nature. The particle size, so we need compared to a micro material, a nanomaterial is more towards the regenerative capacity, and it should have an antibiotic property, anti-inflammatory property, and pro-resolving therapeutics. So it should induce the endogenous pro-resolvents to induce regeneration. So dental pulp complex represents a challenging yet compelling unique regenerative need to preserve the dentition for an individual's lifetime, and using different approaches to modulate macrophage phenotype polarization, we can enhance the tissue formation and we can modulate the cells in the dental pulp complex, which is a significant clinical promise for improving standards of care to endodontic root canal therapy.